Okay. All right, so let's begin. Thank you all for joining us today and welcome. And just to let you know, you may see me multitasking a little bit because I'm also handling the chat and letting some participants in.
Say
Okay,
what it is. Fide, you're our DJ. Say it. Just say it. You're our DJ for today.
learning collaborative DJ.
Yeah.
Hi, Paul. All right, well, thank you so much and welcome to our fourth and last session of our Learning Collaborative on incorporating peer support into substance use disorder treatment. Okay, and this is just a reminder to everybody and also in case we have some new participants that are just joining us in today's session, that the content of this Learning Collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. Also, the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. And with us today, we have Dr. Kevin Lombardi, who is the Director of Research at the National Center for Health and Public Housing. And myself, my name is Fide Pineda, and I am the TTA Manager here at NCHPH. This is just a quick reminder to everyone that your line is muted upon entry. And we ask that throughout this session today that you engage in the chat. If you would also like to chime in throughout the exercises that we will be having on today's session, please feel free to raise your hand or unmute your line. We encourage everybody to participate. Sometimes we may have a few questions about some case studies, and just a reminder to everybody that there is no right or wrong answer. We're all here to learn. So please feel free to chime in and try to engage with everyone. This meeting is
I
also
love
being.
that. Can I tell you why I love that? Sorry, I interrupt.
Yeah, no,
My
of
name's Dr.
course.
But this is how we support each other as colleagues through that sharing. So I love that. And I got to say, I was just on the phone yesterday with a family medicine colleague. And these are difficult times for many of our patients. And supporting each other and sharing strategies is how we get better and how we feel better.
Exactly right. Thank you so much, Dr. Lombardi. And then also, this meeting is being recorded. The slides in the recording link will be sent to you all via email after today's session. Okay, and now I will pass it on to you.
You're not getting away from me, Fide. We have some plans for you in this one. So let's do some quick intros. I'm Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist, internal medicine, and statistical methodology. I've got in the background my MD, my Sicilian flag, and my mandolin, which is pretty much all you need to know about me. And I love this material. I love community health workers. I love folks that work with people who go through substance use disorder because I find that they are some of the most humble and effective clinical practitioners we have. Fide, tell us about you.
Yeah, so again, it is a pleasure to meet you all virtually. My name is Fide, and I am the TTA manager here at NCHPH, and I essentially help support our team in providing all kinds of TTA to all of the health centers and their amazing workforce. And I've been here with NCHPH for about 6 years now, and it's been a rewarding experience for me because I have grown in my career. And now I'm finally about to finish my MPH, so I'm very excited about that. And yeah, this is just some background information about myself right now.
Fide is what we call a multidisciplinary DJ, for sure.
Thank you,
Let's get
Gil.
into it, guys. We got some exciting stuff to look over. You can go over the next slide and go one ahead of it because you know I like my clip art. And next one, please. So let's get right into it. Today, I'd like to look specific. We looked at the feedback, what you guys have seen, what you like seeing, what you want to see, and we went straight to the research and said, how can we look at some promising practices that really pull into details on how to properly implement peer support and the places and spaces where it's effective. Let's take a look at what that data tells us, how they set up the programs and administer them, and the kinds of results that they get. What I'd like for you is to, as you're thinking about this, think about your own implementation. How are you guys providing your services? And are there anything, tips and practices from these that might be helpful to you? I will highlight them as we go through. And as usual, we'll be throwing Fide in here because as a budding epidemiologist, she obviously knows all the answers. So she's going to give them to us. Right, Fide?
I don't know if I know all the answers, but I'll try.
Okay, so let's see. So we're starting here with Jennings et al. And at a certain point, Fide, I'm going to ask to take um, the screen, but this was a fabulous paper that looked at specifically in the emergency room, implementing substance use peer support services starting in the emergency room and then following the patients longitudinally as they grew and developed. And the comparison group was folks that were not getting peer support. They were getting the treatment as usual for their condition, excluding that. So let's go to the next page. And this is just a better picture with the link. Next page, please. So I'm going to tip into the methodology of that in a moment, but I want to put our second paper that we'll be going through here. Another place where peer support has been studied and found to be very effective is in persons returning from incarceration. This study looks at the details and it has some incredible information about just how supportive this intervention is for folks that are transitioning from an incarceration state. The U.S. incarceration rate in the population is both the biggest and one of the biggest in the country. In the world. Folks who are post-incarceration have increased risk of substance use disorder, and if they are past users, that's one of the times when they are most vulnerable for relapse. Among the things that we can do to support them is implementing peer support at the time that they transition into the community. And what we found with this and other research is when we have someone post-incarceration and we are transitioning them into the community, there is a structure of support that the peer support is able to build with. If there's a parole officer, they can create a relationship with the parole officer. If there's a risk of relapse, they can help to navigate the creation of a relapse plan. For folks that may not know what the resources are that are available for them post-incarceration. If you're coming from the community after not being in the community for 5 to 10 years, all of the resources that you may not have been aware of or may have been aware of, they may not exist anymore. There are all these new systems that need to be learned and navigated. And that's difficult for anyone. If you're also challenged with a past medical history of substance use disorder, the risk of relapse is something you'll need to navigate as well, which adds sort of complexity. It adds a great deal of complexity to that process. Hence the importance of the peer support professional. The peer support professional has personal, emotional, and corporeal knowledge of how to manage those resources. And in a care team that includes a community health worker, parole officer, and so forth, you can create a web of support for an individual that's post-incarceration. These individuals often require help with employment, with job training, and so forth. And if your health center has those resources available for patients, when you have folks like this and you find them as they're transitioning into the community, it's the ideal time to implement those. We don't want to catch this in the primary care setting or in the hospital when someone's already struggling. We want to be able to find it beforehand, and post-incarceration is the place to do that. Now, if you have resources, if this is relevant to your health center, and I'll say certain health centers, for example, may have a large post-incarceration population. These are the sorts of programs that you should be thinking of. Because if on a population level, if you have a large number of these folks or these folks living in your community, you're going to see that show up in your exam room. You're going to see it show up in the emergency room. And that time between leaving incarceration and your first showing up in the emergency room after a relapse, those are very precious moments for supporting these individuals, both as patients and as individuals that are transitioning from incarceration. So, what do you think, Fide? Is this an important intervention for our incarceration population? Did I sell it to you?
I think so, yes. Especially when you look at the results of this study that said it contributed to lessons learned. And also that the treatment group did see improvements in measures of treatment motivation and self-efficacy. I think that shows that it is effective in some way. So
100%, and you really got to the meat on that. We all need to ground ourselves in the math to a certain extent, right? Even the laws of physics constrain us, and the methodology here had some really powerful points that tells us that not only is the research a way to design your own intervention or take pieces from it, but it also validates the tool. And when I hear what you say, that's powerful to me, and I'd like to focus on the reasons why. One, it's clinically valuable because it tells me what I'm doing has clinical grounding. And if something is going into a medical record, it's got to have that, folks. You've got to be able to have that clinical underpinning, that data underpinning to your clinical actions. So as a physician, I'll say that. If I were someone who was in the position where I was writing grants or creating programs or managing or overseeing programs that are related to this, I would say that's valuable in a second way as well. In addition to clinically supporting this patient, this data is also very prime real estate for your grants. This is information that helps to solidify why an intervention is important, and it's the sort of things that you should share with colleagues, business development associates, and so forth, colleagues as well, when you're trying to grow new programs, apply for grants, and so forth. Much like clinical practice, growing programs and managing a health center is often best, almost always best. In fact, I haven't seen a reason when it's not, a situation when it's not, when it's focused on the data and what the data tells us. So thanks for that, Fide. So I'm thinking that maybe we should look over the study with for a little detail and see if we can extract some promising practices out. Next slide, please. Wait, I'm not seeing. Okay, I'm seeing your screen now. Okay, so just quickly how they designed the study. We have individuals in the emergency room, and they were allocated to one of two things: either the support system, which I'll go over in a second. It was the peer support system that they designed, but of course, peer support is a category for many different services. And the other was the treatment as usual, which is the substance abuse treatment as usual, included mental health and pharmacological treatment as the protocol designs, but did not include substance use treatment. And I will say also, when I'm looking at the things that really stuck out with me for this to help understand this population a little better, prisons aren't typically, I was unaware of this, but prisons are not typically equipped to address reentry needs and substance use disorder, both in the prison and when someone is going post incarceration. So they're often going from a very resource poor environment when they're coming into the community, which really emphasizes the need to provide these supports. And looking at sort of what this study told us, we're looking at things like motivation, right? These are very core components of what prevents relapse from happening and pushes someone to get resources. Motivation is not an ethereal term. It's very specific clinically, and it's very specific in this circumstance that if someone is provided with peer support service, they express motivation at much higher rates. And what we also see is that they use the services at higher rates and they have lower risks of relapse. That is such a huge deal because when I look at that and I see those numbers, what I see is folks that are surviving who may not have survived, many, many of them. It emphasizes the importance of substance use disorder in allowing people to survive this very scary chronic disease at a particularly vulnerable point. Also, well, that was the point. Moving on, though, next slide, please. And so looking at what the system they used actually provided. So it was 12 months of what they're calling support service, in which a trained and licensed peer support mentor offered guidance, support, and coordination of treatment services. Patients also received a $700 voucher to cover costs of reentry services and so forth. And the peer support individual was responsible for tracking how the mentee was doing, seeing if they were following through in services, attending their meetings, seeing their parole officer, and so forth. So what this tells us is, one, peer support works, but when we're talking about peer support, we need to look at the constituent elements and how they help patients, because those are the things that drive the outcomes. So specifically, things I'd like to focus on here is the support and guidance. That is the one-to-one emotional understanding, knowledge of the environment the peer support individual is able to give them. That's when in the situation go left instead of right. These are the real life experiences. These aren't just story. This isn't just storytelling. It provides a map and a roadmap to recovery for individuals that are hearing that. And if we consider someone who's post-incarceration, this is a very valuable and impactful time in their lives to have those conversations. And I think that really underpins how we see how much peer support helps here. But also, specifically, they measured coordination of treatment services. And for any population that's dealing with SUD and going through peer support, that's a core constituent component of giving the mentoring services, giving the peer support services. But this research emphasizes how prominent that needs to be. And that's critical, one, in your selection of peer supporters. What systems are they familiar with? And you can tell that through their history, through their narrative. How are you linking folks post-incarceration or when they are going into the peer support situation? Are you linking them to mentees that have certain underpinnings in their stories that may provide positions of strength? For example, if we have a post-incarceration individual, the peer supports in this circumstance were post-incarceration themselves. So that provides a level of service to the patient that goes to the next level and really does save lives in this circumstance. Next slide, Fide. And just kind of looking at the highlights here, Fide, can you go over these here? And if you got a 2 cents to add, this is where you put it in.
Sure. So some of the highlights, studies of recovery coaching in the reentry settings have lacked methodological rigor. Researchers piloted on randomized controlled trials of peer recovery coaching for recently incarcerated persons. Results show reduced drug use and increased self-efficacy and treatment motivation, just as we were mentioning briefly earlier. And this pilot study also contributes to lessons learned for evaluating reentry recovery coaching.
Now, I have a challenge for you, Fide. Say you are a community health worker or a social worker or someone who's working directly with patients, who's involved in the pipeline of getting someone into peer support therapy. Um, what does this tell you? What what does this actually say? Because it's kind of it's confusing the way they word it. What are the actual things that are important to pull from this? I know this is
Uh,
if you need to phone a friend, phone a friend. This is a hard one.
yeah, at least from what I can kind of try to infer from this is that the last two bullet points will be something that I would try to focus on. Just the results that it showed reduced drug use and increased self-efficacy, and how that can be implemented in like the program that I would be trying to start as a
Does
CHW or social worker.
does it tell you something about priorities though? How this population is a priority?
Yes, absolutely. I think so.
Yes. And that's one of the main takeaways that's really so important from this is at least resources are limited and we are limited by both mathematically how much we have and how efficient we can be with it. And a partnership with a nonprofit or organization, the prison itself is an excellent opportunity for health centers that are impacted by this quite a bit. And I'd consider that if I were you. Next slide. That's my takeaway. That's the end of the theater of Act One. So looking at other populations, individuals experiencing homelessness are another very high impact population. And when I think about that, I read the data and I reflect, I see a lot of similarities in how support helps them versus individuals that are post incarceration. And when I'm thinking about those, I see the importance of navigating a whole new environment. When someone is, in particular, transitioning from being unhoused to housed, everything in their life changes very quickly. And there is a certain limit in how much we can adapt to new environments. It's experienced as stress and disorientation. And the results are it's a very difficult time for people who are transitioning. Now, imagine someone who's going through that, who's also dealing with substance use disorder and a history of substance use disorder. Now, Fide, if I were to ask you if that individual has a higher or lower chance of relapse just based on that information, what would you tell me?
I think it would be higher.
Way higher,
Mhm.
100%. Because when we're looking at substance use disorder and relapse and what really drives people towards relapse, if you took risk of relapse and you took psychosocial stress, they're the same graph. And the reason is this is one of the major drivers. So when we're able to provide peer support to individuals in this circumstance, we're able to provide a very comprehensive psychosocial foundation for them that is just so important. In similar ways, and when we're having ideally a peer support individual mentor who has experienced homelessness before, the wealth of personal knowledge of how to navigate those resources, not just use this resource, use that one, in this circumstance, talk to this provider, but really the corporeal understanding of having dealt with that fear, that stress, and so forth on a personal level. There is a level of storytelling and narrative sharing that mentors and mentees are able to do that no other provider can give. It's just we cannot get to that level of intimacy. And that really emphasizes the importance of the peer support in this individual in the circumstance of an unhoused individual. I've served individuals who are unhoused for most of my career, even before I went to medical school. And if you, and I will say I've been published on the topic a number of times, and it's something that I often spend my hours thinking quite a bit about is how we can support these individuals more. I will say when I look at the data about substance use disorder and about peer support, and I remember having met those people and heard the things that came from their stories, These are individuals who often very critically lack social support in their lives, very critical. And for those who work with them or have been one of them before, you understand that that's quite an understatement. When a peer support individual steps into that circumstance, when it's a good match, when they are able to help each other, that is a life-saving relationship. And if you facilitate that in your work or you are that person, good for you. So that's what the data tells. That's my perspective of what the data tells us. But let's look at some programs that I thought were super interesting and may help those of you in program design and implementation. I'm stealing the screen, Fide, okay? Okay. So some of these are hard to get to, so I thought let's just pull them up and take a look. So and Fide will go to her screen when I'm done and show you where the link is. When you guys get the slides, are we sending the slides, Fide?
Yeah, we're gonna send them right after the session, which is gonna include all the links. Mhm.
Okay, okay. So, for those of you who are in a program management role, SAMHSA provides grants through a notice of funding opportunity every year, and it's for programs for individuals who are experiencing homelessness. What they support is this, and I'd like for those of you who may be in a position to apply to hear me on this. If you're provided integrated mental and substance use disorder treatment or other recovery-oriented services, or efforts to engage connected clients to enrollment resources for healthcare or coordination of housing and services, that is a lot of you in the audience today. I know what your organizations do, and if you are interested, I would recommend taking a look at the link. For these competitive NOFOs, it's good to have them and look at them ahead of time and prepare for an application when it's released. But what you can do is go ahead and look at the main page at the current grant announcements. You can search for TIEH, which is the name of this grant, and you can find it. So what this pulls up is for those of you who write grants or are interested in, this is a great way to find the playbook to success, is you can find every organization that's received funding and what they've received. Now, if you're in a position to write grants and you want to know how to be successful, that's very valuable. But I'd also like to tell you another really valuable takeaway from this website is you can look in your city and where you are, and you can see other folks that have received these grants. That means that they are providing those services, and trust and believe they would love to have a conversation with a potential partner. You should look in your area to see if there are any recipients of this funding and put that into your partnership quiver. If you notice that there aren't any recipients in your area, well, that seems like a great opportunity to write a grant. So that's my subtle push for those of you in that position. If you need help, email me. Fide, could you go back to your slides and take the ball for a second?
All right, great. Can you see the screen? Yeah.
I cannot. It's still mine. I
No?
can stop. I think I stopped. It's yours now. Oh, there you are. I do not yet see your screen though.
Hmm. Let me try it again. How about now?
Yeah. So next slide. There you are. Next slide.
Thank you.
Okay. And a blurb on finding those folks and how helpful it might be. Next slide, please. Okay, so let's look at some competencies and look specifically at this population and what we can do in the field to help them. So we've talked a little bit about mentorship and navigating resources and what that provides. But when working with individuals who are experiencing homelessness, there are certain competencies for the peer support provider that really need to be emphasized. So the great thing about this, and I will say, go to the resource, it's up there in the top right, is it provides, this guide provides a structured manner to assess and to, well, it provides a structure for providing services. And for those of you who are in a position of organizing, managing, or overseeing a program like this, I would recommend looking at those competencies and see how you are teaching them, see if these are being done during the mentor-mentee relationship, and talking to your staff or providers. If you are the provider yourself, check yourself. See if you're doing these things with your patients. Are there additional strategies that might help you in certain circumstances? That's what I do when I'm reading a toolkit. That's what I recommend as well. So next slide, please. And this was really cool because I love when publications take the data together and do the peer literature review for us and present us with the recommendations in such a clear way. But this looks at types of the specific competencies of support, breaks it down to the emotional, the informational, the instrumental, and the affiliational. Emotional, this is providing empathy, care, connection to the patient. It provides confidence and self-esteem, which we all know are superpowers. Informational, there's the data, the information about where to get providers, where to go to, how to navigate systems. These are very different things, Fide, of course, right? The instrumental, that's the concrete assistance, things like a relapse plan, things like a personal guidance on how to navigate resources, and the affiliational, facilitating connections with others to get them into a healthier lifestyle, connecting to folks, talking to folks, recreational activities, social activities, and so forth. These are the core competencies of how peer support individuals are typically evaluated, and these should be the core competencies in how we structure our resources and how we structure our interactions. And I will say, when looking at peer support individuals in really any clinical clinical setting, there is let's say a spectrum between structure and lack of structure. And what I'll say is making sure your peer support providers are licensed, have experience, and are appropriately linked is so important. But if you provide too much structure to those interactions, it takes the opportunities for individuals to have their, what I like to call bluegrass style conversations, and really just talk as individuals and to grow their relationship and so forth. So what I tell you is, if you are in a position of program management, or if you are a provider yourself, think of that difference between structure and openness, the bluegrass conversations, as I like to call them, and I love to say I call them that too, right, Fide? Um, and ask yourself where you fall on that spectrum, and if you are providing enough space for peer mentors and mentees to connect, or if you're not providing them with enough structure. It really is a give and take, and it takes active thinking to really hit the sweet spot. So next slide, please. And of course, the more core competencies here. I won't go over these exhaustively because I really want to spend some time on a case study, but there are some important ones here. So the lived experience of recovery is one that is worth its weight in gold. That's where you get the personal connection and the narrative. There is no better way to get an individual to understand something than to tell them a story. And that's not just my opinion, that's what a surfeit of anthropological, biological, and medical evidence tells us. It is the best way to get people to remember things. It's the best way to communicate. And in a particularly emotional subject, such as substance use disorder and recovery, that effect is emphasized. So the personalization of the support is also very important too. How do you personalize support? One, making sure you're matching individuals appropriately. Who does this? And I will say the people who are really good at it really know their peer supporters and really know their community, and they really just do it and are able to rely on their knowledge of these individuals and what's made them successful and link them to someone and say, that person has a history of incarceration and a history of domestic abuse. Wow, Sophie would be great for them. And it's amazing to see the folks do it. And what I'll say is, linking people to peer support individuals, mentors to mentees is very complex. Give it the time and the consideration that it requires. And I'll ask Fide to go to the next slide, please. And the exhaustive list for those of you who are interested. Next slide. Yes. So I did want to spend some time to talk about certification. Now, the recommendation is that peer support providers have a standardized certification. There are a number of different places that provide them, but there are standardizations that are very, very important in your peer support professionals. This interaction is not without risks. The quality of your peer support individual, and that's the quality of their experience, their intentions, and their relationship with the patient is really key. And making sure your peer support providers are licensed is really so important. And I can say that all of the research I've given you is with those folks who have that certification. So not much is applicable outside of that setting. So you are really in the Wild West if you're using individuals that don't have some sort of training and support. And I'd like to divert you where you can look to find that. Fide, I'm taking the ball.
Mm-hmm. Yep.
Bam. If you want to be real fun, you can act like you're throwing it. I do that.
There you go. Just showed up on your screen.
This is how we argue, folks, this Monday. Okay, so here we go. And this is in the link. So ICRC develops the examinations and the standards on national level. You can follow this side, but you don't go to them for the provision of service. You go to local providers for that. They provide the training, much like many national licensing systems work. If you're an EMT or you're a medical doctor, you have your version of this. Mine's expensive. But these resources look to be, in many cases, free. So that's excellent and a major removal of a major barrier. I can't speak to all of them. Yes.
Yeah, Dr. Lombardi, do you mind putting your screen in full screen, please?
Full screen? Oh, yes. I'm sorry. Thank you. So you will, and I will do less dancing here. So you can find resources here and find the trainings, and you can find available training dates and register for harm reduction specialists. That's lovely. So those links are available, and I will ask Fide to wait one moment, Fide. Actually, I don't know. Can you have the ball again? And we may need to keep throwing. So there you go.
All right, sure. Since I'll be sharing the screen, it may be a little bit hard for me to paste the links.
Watching the chat.
Okay. There you go.
So this is like a workout, like we're throwing a medicine ball. Yeah. So the links at the bottom left. And so take a look what it has. If you're a community health worker, why not get the certification? It's an extra thing to put on your resume. It's an extra competency. If you are not providing the service, but linking someone to it, get the certification yourself. It's going to teach you how to run your program better. It's going to give you more of an understanding. So that's what I strongly recommend for all of you. So next slide, please. Case study time. Let's do it. I love case studies, Fide.
They're one of the best ways to learn, I think, because you apply what you learned.
100%. Do you like case studies? Do you want to do one?
I think the audience.
Let's do it, Fide. I'll take that as a yes. We're going to do a case study. I'm going to start with me and Fide, but we're going to talk a lot about some things. We're going to talk about this case that's related to relapse planning. And then we're going to talk about what we can do for folks and making sure they're getting a good relapse plan with their peer mentor and what kind of information should be in that relapse plan. Relapse plans save lives and not a small number of them. So here's what we got. A 30-year-old man is in recovery from opioid use disorder. He meets with his peer support mentor with after unexpectedly running into an old friend that he used to use with. The encounter brings up intense cravings, and he admits feeling unsettled, wondering if this means he's at risk for a relapse. What do you think about this gentleman, Fide? What do you think? What's coming to mind?
I think that unfortunately his environment is not really helping with the relapse. The fact that
Mm,
he is just constantly being exposed to substance use or opioid use in this case, it's not really helping a lot.
and you're getting that from the friend he used to use with, right?
Mhm. Yeah.
I agree, and I think that's a dangerous situation. And if I were to tell you how often the story of how did you start using again ended with that, or like, oh, that was the first thing that someone told me in their personal story, wow, that's a lot of people. This is a lot of emergency room visits started with running into an old friend. I can't emphasize that enough. So
Mhm.
I want to pick on Rebecca Barra. I see you there, and I need a community health worker perspective. What do you think about this patient? And if you don't answer, I'll call you.
Good morning or good afternoon. I know you'll call me. I tried to hide. Um,
You can.
so
Yeah.
hi everyone. I'm Rebecca Barr. I'm a community health worker down in rural Florida. Um, so yeah, I agree with Fee. The environment sometimes is 100% the problem. What's going on around you that just kind of gives you that trigger. Unfortunately, where I am, sometimes it's very difficult to get out of that environment. We're such a small rural community. You know, you can't even go to Walmart sometimes without running into someone you don't want to meet. When my son was younger, you drive in the parking lot, go to Walmart, and then I drive right back out again because we have people that I didn't want my son to associate with, or I didn't want them to know that I had a young son. Now he's older, I don't care. He's grown. But sometimes it's just that difficult. You can't even go to Walmart and to avoid, they're everywhere. Sometimes the people you want to avoid. And so the best thing that, you can do is tell them, well, shop at Walmart at 6 a.m. when they open. Nobody's there. Or, just these little things that hope make a little bit of sense. But it's always, I always think it's environmental. Sometimes you just can't get out of
Mhm.
where they are, especially here.
Mm.
There's no way out.
You know what's really scary, and that's that. What that to me is, and I've worked in rural communities. It's scary
Hmm.
you are an individual that's in your small town and you know exactly where the stuff is, you know exactly where it's going to be, and it impedes you from going to the one place you need to go because there's one grocery store or there's one post office. It really cuts down the in a way that's really unique to being in a small community. And when I hear what you're saying, seeing Rebecca, I think of sort of just the fear and the stress that someone who has a history of substance use disorder is feeling if they're constantly being exposed to reminders of substance.
Yes.
Mm.
Yep.
You want to give us a little pitch about the Florida CHW Coalition?
Sure. So the Florida
You
Community
get a
Health
lot of
Work.
Floridians. You get a lot of them.
Okay. Well, the Florida Community Health Worker Coalition is the statewide coalition. We have a partnership with the Department of Health where we advocate for the education and of community health workers, getting them into communities. We have 31 rural counties that we try to get into, but we're also in the cities. Basically, we coordinate care. We try to get into areas where there is not healthcare deserts, whether they're in the city or in a rural community. Right now, we have one where we're trying to get 400 and something odd women to get tested for both breast and cervical cancer, and that is a state-funded grant. We just gotta let the people know, and a lot of times it is that. What we are doing as community health workers is we are letting the communities know that these programs are available to them. We are setting them up with programs, and we are getting them where they need to be to take advantage of this.
I love it. And what I'll also say is when I talk to organizations like yours, and yours in particular, the times are changing for CHWs, and
Mm-hmm.
what we're starting to see is organizations like your own do more political advocacy and do more outreach for your patients. And I wish you guys the best on your endeavors supporting your patients. You do such an incredible service. Thank you.
Yeah.
Uh, and I'll bill you for the time. I'm just joking. For your advertising time.
Okay.
It's Fide that takes care of those. I will. So let's see. Do we have
Yes.
any? Let's go to the next slide. We got a lot to do here. Okay. So the mentor listens without judgment, and that is a much harder thing to do. It takes for some individuals more than others, but becoming a non-judgmental presence is much more than what you say. It's how you carry yourself, it's how you speak. When you see these folks in action, someone who's and sometimes peer support professionals have been doing this for years. It's like seeing a theater. They're so good at making people relaxed around them. It really is a skill and a competency that you can't get without that experience. They deserve our respect for that. That's for sure. So in this situation, mentor listens without judgment and asks, what's helped to keep you on track before? As they talk, the patient realizes that stress and isolation made him more vulnerable and that he hasn't been reaching out to his support network as much. Together, they brainstorm ways to strengthen his recovery routine, including reconnecting with a recovery group and having a trusted friend that he can call in moments of temptation. Fide. Oh, you know what? Before Fide, I'll throw it to the crowd. Fide, if you can do your with the hands, please.
Right.
I'll say, what comes to the forefront of your mind about this patient and what they need? And I'm going somewhere specific, but there's a lot of answers to this. So, Fide, do you think?
Just everybody, please just you can submit your response in the chat, or you can also just go ahead and unmute your line and chime in. Let us know what are some of the things that stand out to you about this patient so far. One of the things, of course, I know it's like highlighted here, but of course, is the fact that he hasn't been reaching out to his support network as much as before, and he's experiencing social isolation. So that really stands out to me.
Oh yeah,
And I
social
think,
isolation.
yeah, and that is a big issue that I think is just happening right now across the nation as well. So
Mhm.
tackling that and also figuring out how this patient can be connected to peer support services to help him with that.
You picked a big one up there. So social isolation. What I'll say is, if anyone has thoughts about this patient and social isolation, speak now or forever hold your peace, because we're going to spend a moment on that.
I'm gonna pick out Nisbet Rios. Would you like to chime in? Okay, Latasha Sullivan. And then we did get a response in the chat from Rebecca saying self-realization, knowing there is a battle and willing to do something about it.
Mm-hmm.
Oh
Mm-hmm.
yeah, Jennifer Yepes. Well, hi Jennifer, how are you? She said
Got it.
creating.
Got
Yeah.
the she got it. Yeah. So let's pull Jennifer up, because
Mhm.
she's going in a direction that if we miss, we made a big mistake.
Okay, Jennifer, I'm not sure if you're able to unmute your line, but if not, that's okay. I'll just read from the chat. Creating, yeah, she's saying, and then the word together. That's what stands out for her.
Yes. Mm-hmm. Oh yeah, no, of course. We're so thankful for your participation in the chat. Of course. What I am seeing though is creating a revision of the patient's care plan, and that is so critical here. This patient has expressed that they are at very high risk of relapse, and it is time to get a relapse plan in their hands. This individual may not have a relapse plan. If they do, it needs to be revised because they are at high risk. This is scary, folks. When someone comes in like this, you're looking at someone who is in a very dangerous crossroads in their lives, and the relapse plan is a life or death thing. And I put this in here for that reason. And because relapse planning isn't just writing some stuff on paper and putting it in your pocket, although I have seen that more times than I would like to admit. First of all, what are in these things? Relapse plans. First things with triggers, and ideally you want someone to sit down with a peer mentor and to work through these things. And your peer mentor, through the training, will know how to do this. Through the licensure training and so forth, they go through these processes. And what you see is over the years, people will get very good at it. But identifying the triggers, this is harder, easier said than done. Identifying triggers takes a lot of introspection. It takes a lot of time thinking about one's daily tasks, daily things that they do, their exposures, and it requires a lot of honesty with oneself that is challenging. So this is a conversation that happens, and a list of triggers is the result. Having those on that list and looking at that and checking looking at those and meditating on those and thinking, how can I manage my triggers? How can I manage my environment? That's where the conversations happen with the mentor and mentee, and that's where knowledge is passed. And remember, human beings think in stories. Doesn't matter who they are or where they're from, our brains are designed to listen to stories and to understand stories. And that's the best way to impart clinical information, is by stringing it into a story and a relationship. That's what I love about this stuff. Makes you feel all fuzzy when you think of the results of how it helps people and saves their lives. So early warning signs, this is one of them, right? This patient has identified the early warning sign. They're stressed. And oftentimes, stressed is the way that one would describe it. It may be fear, it may be anticipation, it may be a variety of different emotions, but it will start with stress. And if a patient is trained to understand that if stress is popping up in this circumstance, I need to take a look at my safety, or I need to meditate on my triggers, that is life-saving. That is life-saving. Another one, the support network, the trusted people that they can call and talk to, a healthy routine. And we do this in North American management. I called Fide this morning and I was like, did you work out? Did you do your things? We do that to each other to make sure you're living a healthy life, right? Do it for your patients too. But in a relapse plan, you write those down so an individual can look and check.
Like,
What I will say, and self-compassion strategies, these are all things that are fairly self-explanatory from a clinical standpoint. From the perspective of actual implementation, they are much more complex, and it emphasizes the importance of having trained and experienced patients with them. And before we wrap up, I do want to focus on next slide, please.
Oh, and then also we just wanted to add that we did receive some additional feedback from Jennifer saying provide Narcan, fentanyl strips, silencing strips, and harm reduction for this patient.
That should be a core component plan and the 100%. 100%. Where is the Narcan? How can it be accessed and so forth? Thank you so much for that. That is a life-saving medication, and access to it is so, so important for our communities. Yes. Some thoughts as well about technology. There are a number of apps that you can use for this that are fun, and I would recommend looking at recovery apps. Sober Grid, WeConnect, and Lucid are good. I'm gonna put those in. So they work in tandem with a peer support individual and have portions where you can like write down all of these things, put them in a visually and UI friendly way so folks can have access to that information, check it as part of their routine. There should be an emergency contact on folks' phone for relapse. So if there is a circumstance where emergency services are there, they're able to do that. Certain people will have jewelry as well that they wear for that. These are all things that save lives in those circumstances. Respect the challenges that our emergency medicine providers have to face when they find relapse, and understand that having this information available at the scene when the patient might not otherwise be able to communicate is so important. I spent years as a street medic in an area with a lot of substance use disorder before I went to medical school. And the first thing we do is check that phone and see where the relapse connect is. Boom. So that's what I'll leave you with. So thank you so much for joining us. This has been such a pleasure. These are such incredible patients that we learn so much from. And unsurprising that it's also incredible providers that provide this support. So you guys are doing such incredible work. Thank you for your service to your and our communities. And don't be shy. Reach out. Fide, could you take it, please?
Yep. Thank you so much, Dr. Lombardi, and thank you, Rebecca, for participating, and Jennifer, and everybody else who joined us today. We hope that you found this learning collaborative useful and that you're able to implement some of the strategies and promising practices that we were able to share. Please let us know how we did and complete our post-evaluation survey, which is going to pop up on the screen right after the session. And one reminder to everybody that we will be doing a 90-day post-evaluation survey just to see how you have progressed at your health center, if you were able to implement some of the things that you learned 3 months from now. So please be on the lookout for that email. And if you fill it out, that would be very helpful to us as well. Again, visit our website at nchph.org to access our latest publications, webinars, and learning collaboratives. We have more activities that are coming up in the month of March. So you can go on our website to take a look at that. And thank you for participating, and we look forward to having you all participate in all of our other upcoming TTA sessions. Thank you so much and have a great rest of your week.